Hello students, and now I'll try to describe to you the broad ligament hematoma with the makeshift model that I have made. It's very difficult to kind of find a uterus which is demonstrable enough, so I've made this kind of makeshift model for you to understand it better. This happens to be the uterus, and this is the fold of the broad ligament. I have tried to make it exactly the way it is. It's like a curtain over the uterus. It's adherent over here, so you can't actually appreciate it. But over here, the peritoneum, it gives a reflection on the bladder, something like this. Here is the bladder and there is a reflection over here. So what you do is basically you take this loose fold of peritoneum and you snip it. Once you snip it, then you can slowly retract the bladder down, and bladder has gone out of the way, and now you can give an incision over here and you can carry on your C-section. So these are the cornual structures over here, and on which the flap of the broad ligament, it like comes as a curtain. It has two flaps. That's why I have made this. It has got two flaps, the anterior flap and the posterior flap. Okay, now how does the hematoma form? Now that thing has to be known to you. See, when you're talking in C-section, the only way in which a broad ligament hematoma can form possibly is by an extension of the uterine incision into the broad ligament, the retraction of the artery. Now it could be the uterine artery, most definitely. In 90% of the cases, it will be the retraction of the uterine artery into the broad ligament, ligament, and it's feeding here and it's forming the hematoma. Now, one thing, be very sure about any hematoma that you ever encounter. If that hematoma is not increasing in size, and believe me, increasing hematoma in size is evident within a few seconds, all right? Within a few seconds. You don't have to wait for 1 minute to understand a hematoma being formed. So if a hematoma is increasing in size, it will be evident within a few seconds to you, and you can take your precautionary steps. I'll describe to you in a short while. But if the hematoma is not increasing in size, which is again evident within a few seconds, do not touch it. Reason is that every feeding vessel will keep forming a hematoma around it till it starts to put pressure on the feeding artery. So it's the body's mechanism of taking care of hematoma. Remember that. So many nudges and bruises you have in body every day, they are all vessels which are getting ruptured, but they are also getting coagulated, obviously because of the normal coagulation of the blood, and the second because a small hematoma that forms, and that's a pressuring effect over the blood vessel. So remember, even now, the problem with broad ligament hematoma is that number one, this is a very good dead space. A very loose connective tissue, a place which a blood vessel, once it starts filling, there is no end to it, because it's a completely loose and flail connective tissue. What's there to stop it? What will give the occluding effect? It will only be the hematoma. And the number two, uterine artery, which happens to be a very major blood vessel, if that is feeding, then there is no end to the broad ligament hematoma. So number one and the most important thing, that if at all you do encounter a broad ligament hematoma, always and always put your hand like this. Why are you doing that? You're not just seeing the boundaries of the broad ligament, the hematoma, but you're also making sure that there's no gut which comes when you're taking the stitches. Now, after you've put your hand around it, let's presume that the hematoma is increasing in size. Never panic. Exteriorize the uterus, number one, so that you know the boundaries and you are easy and comfortable, because it's such a big uterus where you're putting the stitches. And remember, your incision is somewhere here. The whole fat and the entire rectus sheath and muscle and everything is over here. So to retract this and give pressure and then start stitching it, it becomes very difficult. So just exteriorize the uterus. So half of your problem is done. All you have to do now is to put your hand here, right behind the hematoma, and since you've exteriorized the uterus, the gut has also gone far below. So now you put your hand here just for let's say safety's sake, and you trace the uterine artery. You palpate the uterine artery. Once you palpate the uterine artery, just keep one finger there and ask for the stitch. You take a stitch around, never prick the hematoma. You take the stitch. If suppose the uterine artery is right here and the hematoma is here, you go a little down, you put it here. the stitch. All right. So the idea is basically to stop the flow to the broad ligament, right, to the hematoma. And right now you're only the uterine artery which you think is bleeding enough. Even if it's a small spurter, by the time it will get occluded, pretty sure it's only uterine artery which will not stop, because it needs a real big hematoma to occlude the uterine artery. Even then, I'm not sure. So what you do is, first of all, you will take the angle. You will trace the angle. You will make sure that the apex of the angle is secured, number one. Number two, just to be on a safer side, you will take the uterine artery. You will palpate the uterine artery and you'll take a stitch through this. When your hand is making sure that you do not rupture the hematoma, because right below the hematoma is your hand, and you will obviously guide in such a way that you do not prick your hand. So you are taking a bite around this uterine artery and occluding the uterine artery. So basically, two things you have to do. You have to make sure that you do not prick the hematoma, and you have to take the angle, that is the angle of your incision, and the uterine artery separately. I'll tell you one more easy and accurate way of making sure that you can sleep properly after such a catastrophic event has taken place. Mind you that you have to give blood to this patient, because a hematoma is a big reservoir of blood, and you don't even know how much blood it can hold. So make sure that you do arrange blood for such a patient. One very important way of handling such a case is to take a stitch. Suppose the hematoma has been formed over here. Okay, suppose it was over here. My hand, okay, let me show you like this. Suppose this is the hematoma that has formed. So what you do is basically you take a suture from here to here around this place. So you take a bite from here, over here, right below the hematoma, from here. You take it out from behind, and you take it till here. You pierce here and you come out from the front, somewhere here. And you tie these sutures in the midline. You know what it will do? It will stop the collateral branches of the uterine artery and the feeding branch of the uterine artery. And not just that, it will also hug the entire uterine lower segment, so as to occlude or tamponade any feeding vessel which is going to the hematoma. Despite all these efforts, if suppose the hematoma keeps increasing, the only way then left is to drain the hematoma and to search for the feeding vessel. But that is in itself a catastrophic, step to take. My idea in this case, the steps that I have told you will solve 99% of your problems. You will not land up into problems at all. You will reach the level of hematoma in any feeding vessel, and that will be it. Never ever. And the most important tip is, the moment you start seeing a hematoma, do not wait for it to grow in size. Wait for 2-3 seconds. Stop your incision line, those stitches that you are taking on the incision. Stop there, ask for another suture, and first take care of the hematoma and then go forward. Nub it there and then. How to nub it there and then? You take sponge holding forceps. Okay, nub the hematoma. Take it little towards you. That means, suppose these are the sponge holding forceps, and you drive it like this, and then you take a bite across it and you tie. So your hematoma has gotten inside this. So you've taken a bite across this. So hematoma is not going to increase in size. And 80% of the hematomas, they do not require any additional effort from you. But suppose you do fall into trouble, then exteriorize the uterus. Do not panic. Arrange for blood. Inform the family. Keep track of the vitals. Use an 18-gauge needle and start infusion of IV crystalloids, just to maintain the blood pressure, and of course that will maintain everything else, the kidney function, the urine output and everything. And at the same time, just go, like I said, first secure the angle and secure the uterine artery. And third thing, if at all you need to, tamponading suture over here, the way I have explained it to you. That will take care of 99 or 100% of broad ligament hematoma. With that, I finish the broad ligament hematoma. The other case which I'm asked to discuss is plastered abdominal wall. How to reach the plastered abdominal wall to the uterus for tubal ligation. That I'll cover in my next video.